may not they may not actually be interested in bariatric patients, and for that you need someone who understands obesity. So those are the two core members. I would highly recommend that you have a bariatric coordinator. And sorry, Imran, there's a message that is constantly playing on the screen. I don't know if it's just my screen or it's all over.
No, sir, no, there is no issue from my side.
Okay, all right.
Yes.
So the bariatric coordinator, and one thing that I really like to do and which is very desirable is to have a database which helps you to follow up your patient and track your outcomes. So those are, in my view, the basic requirements for running a program that offers Roux-en-Y gastric bypass.
Thank you. Sir, regarding so patient selection, because for Roux-en-Y, so for in your protocol, any age limit, so like in adolescent age or old age, so because in old age, so they cannot tolerate malabsorptive surgeries. Have you any age limit for your patients?
So I did have age limits in my mind during my fellowship. And when I visited Dr. Higa, I was with him in a clinic, and he had a patient who was 82 and had a Roux-en-Y bypass done 10 years prior to that. And I asked him, I said, did you operate when she was 72? And he said, yes. And I asked the patient, and she said, that was the best decision of my life. So I would sort of divide this question into two parts. When you're at the beginning of your career, then you must have those limitations. And once you've crossed, I would say about 500 cases or maybe 5 years down the line, when you have established center, then those limits extend a little bit. And the key element remains that you are able to safely look after your patient. So for our young listeners, I would say that stay within the age range where you do not pose any additional risk to your patient, either through your lack of ability or through patient's lack of ability to follow up. I'm lucky that in Cleveland, we have a very good setup to look after a wide range of patients. And we have at least 4 patients above the age of 70 that we have operated. 3 of them had Roux-en-Y bypass. 2 of them were revision because of bad reflux and vomiting that needed fixing. But I think I would say that I completely agree with your comment that we should avoid malabsorptive procedures in extremes of age, especially in the later half of age. And the bypasses that we did for older patients, we kept the BP limbs relatively short. And we were aware that, especially in terms of calcium and bone health, we need to be mindful. We need to do bone densitometry. We need to look at the calcium and the parathyroid. So all those elements, and that's why you need a team, a strong team. We are blessed with at least 4 endocrinologists who are very interested in our bariatric program, and they are sort of part of our core team. So all aspects of those patients, and the patients, anyone above the age of 60, we routinely get a cardiac clearance, we get a pulmonology clearance, and we get a clearance from an internal medicine or a endocrinology doctor. So to ensure that there are no hidden areas which become problem later on. The younger age group, I think we have to, doesn't matter how good an operation the Roux-en-Y is, and I truly believe it's a very good operation. But if someone comes at the age of 17 or 18 with extreme obesity, then with experience, you learn that there is not going to be a single operation that is going to look after this patient for the rest of their lives. And at the beginning of my career, I did, when I was in UK, I did Roux-en-Y on a 17-year-old or 18-year-old. And at that time, I very firmly believed that this is the operation and nothing else. But then I started, after 5-10 years of practice, seeing some weight regains and then the limitation of options after Roux-en-Y. And then I feel now that in the younger age group, doing a sleeve gives you more options for future. Although it takes away the stomach, which takes away some options as well. So it's a balancing act. But by and large, I shy away from offering Roux-en-Y bypass to teenagers or people 18, 19, 20, because it limits our options for future.
Sir, thank you. Sir, regarding age limit, you have mentioned a female after menopause. So definitely she is also prone to osteoporosis. Have you any special protocol for such a cases? So to rule out osteoporosis, and if there is osteoporosis, again, you will go for Roux-en-Y. What's your protocol?
So I think if there is a definite osteoporosis, then I would not offer Roux-en-Y unless they have bad reflux or vomiting after a previous surgery, for which Roux-en-Y still remains a very effective treatment option. Again, in those, we would ensure that our endocrinologist is involved fully. If we need to do a quantitative assessment like density of the bone, parathyroid status, but we would be, and this is why we have a multidisciplinary team meeting. And I think I'll just supplement your earlier question where you said, what are the requirements? So one of the requirements in my view is that there should be a multidisciplinary team meeting, and every patient should be discussed and approved by all members of the team. So in my MDT in Cleveland Clinic, my dietitian, my psychologist, or my coordinator have the same veto power as I do. If my dietitian says that this patient is not suitable or she has some concerns, even if the operation is in 2 days' time, we would postpone it. And the same, if our psychologist has a concern, we will not proceed. So unless you empower your team, they will not take the responsibility and take the ownership of the patient. So I think trusting your team members with their skill and then respecting their decisions, I think it's very important, although I still feel that a surgeon should lead the bariatric MDT.
Okay, sir. Sir, as I understand in your protocol, after menopause, so rule out of osteoporosis. I mean, bone density is that is important, and you must rule out this. Then you will go ahead.
If we have any concerns, so in our setup, when a patient comes to now in Cleveland Clinic, 90% of the patients come through either our primary healthcare service or internal medicine service. And they usually, in those age groups, they do a screening blood test and they do some basic screening where including looking for smoking, looking for thyroid problems, diabetes. So they sort of screen those. And if they raise any concerns, for example, if they suspect someone may have high snoring or suspicion of sleep apnea, they would normally refer the patient to pulmonology simultaneously as referring to the surgeon. It's very rare that as surgical team, we have to initiate those referrals. So they're usually, and that's the beauty of working in a system that is now well organized and different parts of the system talk to each other. But if there is any concern at any stage and things get missed sometimes, for example, central sleep apnea can be undiagnosed and can become very problematic in the immediate post-op period and may necessitate an unplanned ICU admission for post-op. So occasionally things do get missed, despite, it doesn't matter how good your system is. But by and large now, the bone health, postmenopausal women, our primary care and internal medicine doctors are quite good at picking those up.
Sir, thank you. Sir, regarding relative and absolute contraindication of Roux-en-Y gastric bypass, so we are interested to hear from your side, and in your protocol, chain smokers, so they are, so are you do Roux-en-Y in such a cases?
So I think active smoking is a contraindication in our center. And patients who have inflammatory bowel disease, where there is a chance that the absorption or the availability of the bowel may become a problem in future, we do not offer Roux-en-Y bypass to those. We follow the general principles that their disease may be well controlled, but the inflammatory bowel disease does change courses, and sometimes even after resection, the difference between Crohn's and ulcerative colitis doesn't become clear. And when I was doing colorectal, I had many occasions when we could not define which disease it is. So a hint of inflammatory bowel disease, that is almost a red area for us to offer Roux-en-Y bypass. Smokers and those people who have defined osteoporosis and who are in the older age range, so that's a relative contraindication for us. And I think this poses a dilemma for me for patients who had sleeve gastrectomy, for example, and there's a twist and they have hiatus hernia and they have reflux and vomiting. So they're very, very symptomatic. And my belief is that repair of hernia and Roux-en-Y bypass remains the best option for those patients. And I still actually have a patient who has a questionable inflammatory bowel disease and has very bad reflux disease and vomiting. I went and repaired the hiatus hernia and tried to untwist and take the adhesions down. His symptoms are a bit better, but I know in the heart of my heart that they're going to come back, and I'm still sort of struggling to find a better solution. So that remains a contraindication in my mind.
A smoker, so you talk with the smoker and he will quit smoking. You ask him 2 weeks, 3 weeks, it is your protocol. So are you trust the patient or no? You will go for nicotine test. So you must check.
I think if it's a primary bypass, then we are quite strict about it. And we very clearly document it on multiple occasions. And we have a smoking cessation clinic, which we refer and offer them to. And we wait until they get a clearance from them. Yes, we have the nicotine test as well. If the patient comes and tells us that they're not smoking, but they're smelling of tobacco, then obviously something is not right. But in the end, Imran, if it's an adult patient, then it's a contract between us and the patients. We cannot be the absolute sort of the decision makers in those situations. We have to trust our patients, and the patients put their trust in us.
Yeah.
And as long as we have explicitly discussed this, we cannot control 100% of the situations that our patients are in, but we counsel them well enough, we document it well enough, and we try to avoid knowingly, because I had a few patients who actually stopped smoking, just your point, and then after surgery, they started and they had ulcers, which were very difficult to treat. And the worst combination, as you know, is smoking and non-steroidal anti-inflammatories.
Yeah.
A combination of those two can lead to very difficult ulcers, which are very difficult to heal. On this point, I must sort of bring another thing which might slip my mind later on. A patient with Roux-en-Y gastric bypass who has ulcers, and you've ruled out the smoking and you've ruled out non-steroidal anti-inflammatories, and you feel that the patient is doing everything you asked them to do, then the next thing to consider is possibility of a gastrogastric fistula. And sometimes they are very difficult to actually identify and to demonstrate either on endoscopy or on X-ray studies. So that is something we must keep in mind. And even if these are more common in the older version of the Roux-en-Y when it was done as an open surgery and people did a non-divided gastric pouches and the staple line sort of opened up. But even in completely separated, the modern way with vertical pouch that we do these days, if there is a subclinical infection and a collection between the two parts, then that can lead to an opening between the gastric remnant and the pouch. And I actually had this case while I was in UK, a lady, insulin-dependent patient who responded very well to bypass. Insulin requirements went off, she became better, and then 6 months down the line, her insulin resistance came up, she needed insulin again, and she had recurrent ulcers. And at that point, we investigated, and the first set of investigations, we didn't find anything. At that point, it was the earlier part of my career, I phoned Calvin Higa, and I phoned David Kerrigan, who was my trainer. And I said, this is the situation, tell me what to do. And then they both advised that look more carefully for the fistula. And I found a fistula, which I then divided, and ulcers became better and her diabetes became better. So on this point, I must say that, especially for our new bariatric surgeons, you must find someone that you trust and that you want to learn and have an open connection. I have stopped operating and phoned through the operation when I found a difficulty to people who could guide me. And I think there are plenty of people with experience who would be happy to do that to their trainees. So my advice would be always have people in your phone that you can call for advice when you come across unusual situations. And even with experience, you sometimes come across those situations.
Sir, excellent. Sir, in one of our last question of Preop is, what is your protocol of Preop endoscopy and about H. pylori eradication?
So Imran, if we all have limitations on our practices, self-pay, insurance-based or government-based, when I designed our protocol in Cleveland Clinic, two things I put in. One was endoscopy and second was ultrasound scan for the gallbladder for Roux-en-Y. The way the insurance processes this, unless you put that there's reflux symptoms or history of ulcer, and I felt a little dishonest writing something just to get an endoscopy in the notes, which was not true. So yes, I specifically ask the patients if they have any reflux, and if they have any reflux, and we all can have reflux when we eat spicy food or eat too much and all that, then I can do an endoscopy. So my preference is, if I have my choice, I would do endoscopy on every patient undergoing bariatric surgery. A category, if patient has history of upper GI cancers, and you're going to do a Roux-en-Y, then you must do an endoscopy before surgery. If they have a history of anemia, and women often have anemia, usually due to heavy menstruation, then you must do endoscopy before. So those two categories, you should not offer Roux-en-Y. I actually, if there is a history of gastric cancer, especially in the first degree relative at a younger age, I try to avoid doing a Roux-en-Y. And that is, I think, in terms of contraindications, if there is that history, then that would be a relative contraindication, because you cannot access the gastric remnant. So So that's for the endoscopy. So what was the second part of your question?
H. pylori, sir.
H. pylori. If we do endoscopy, we always biopsy for H. pylori, and if there is H. pylori, we do eradication before surgery. But we do not routinely do breath tests or other means to do H. pylori testing unless we're doing an endoscopy.
Sir, now your number is in tetra, so definite thousands of cases you did Roux-en-Y gastric bypass, and definite thousands of cases you did pre-op endoscopy. How many cases? So you changed your just plan. So yes, due to endoscopy, yes, this was the finding, and I must go for this.
The true answer is very rare. Okay, as keen as I am to do endoscopies beforehand, but I cannot say that, okay, my practice changes routinely because of doing the endoscopy. I think one thing we know that not every patient who has reflux symptoms will have a hiatus hernia, and not every patient who has a hiatus hernia will have reflux. So occasionally you find, I would say about in the last 5 years, there may be about 6 or 7 occasions where we had unexpected findings. For example, I had a patient who had a gist next to the gastroesophageal junction, and which was unexpected, but it was just at the junction. Or we had patients who had large hiatus hernia completely asymptomatic beforehand. So on those occasions, we were planning sleeve, and so we changed our plan based on the endoscopy. But by and large, I think my practice in UK, in the Western population, we see a lot more Barrett's esophagus with reflux, which is far less, surprisingly and thankfully, in our population in the Middle East, and that what I hear in Pakistan as well. So if someone has Barrett's, then I would not offer them sleeve gastrectomy because of the potential risk of reflux and further exaggeration of that. But that is something that people would have different views on. But endoscopy sometimes changes your practice, but more importantly, it clears your mind that what you're doing, you are not leaving an area unexplored. So in my mind, when I look at the patient and the decision making, the first thing in my mind is patient safety. Second thing is the benefit, and the third thing is the cosmesis. So the safety always remains at the top, and endoscopy gives me that feeling that we have excluded anything important, which we may regret later on.
Thank you, sir. Sir, excellent. And also, in my opinion, a great message, especially for our youngsters. And in Preop, MDT was at the top. And if you're going to start bariatric surgery, please so follow these things, then there will be less complication or difficulties. So now, now, sir, we will talk little about technical points. In this, now I will ask some question because we have also viewers from all over the world, and definitely this video will remain and thousands of viewers, and many of them they are newcomers. So what is your standard of gastric pouch? Is the size of gastric pouch is important for marginal ulcer and weight regain?
I believe it is. Although Roux-en-Y gastric bypass is not primarily a restrictive operation, but one of the mechanisms that helps them to lose weight is the decreased capacity to eat. And I think it's it's not the only factor, but it is an important factor in this journey of satiety. The gastric pouches that I was trained to do from my fellowship to then looking at Calvin Higa, they are small pouches. So they are vertical pouches, lesser left gastric artery based. And my usual fire is a 45 at the bottom, which is the transverse fire, and then 60 vertical. And if the pouch is appropriate size, then I would need another 45. So if I'm using more than 260 fires on the for the vertical fires, then I feel that I've not followed the right path, and there is a risk that on the posterior aspect, I may leave a lot of fundus. So when you're deviating a little bit laterally, and you would need more fires to come back to the gastroesophageal junction or angle of His, that means that the pouch capacity will be higher, especially at posteriorly. So when I create the pouch, I usually try to clear all the area, and I have an instrument which is like a Goldfinger, but it's a 10 millimeter instrument. I insert it and I come up at the top at the angle of His. So then I have a very clear view of the posterior wall. At this point, and one technical area, if the patient has an undiagnosed hiatus hernia, and when you're forming the pouch posteriorly, sometimes if you're unaware, then that posterior big pouch will result in requiring a lot of staplers. That's why, and I would say that if you really want to do bariatric surgery, you need to be comfortable with hiatal dissection. To me, that is one of the basic requirements. I think you can train anyone to do a basic bariatric operation like a band or a sleeve gastrectomy, but to do a good bariatric operation, you must be comfortable with the anatomy of the hiatus and to deal with it. So that, I would say, to me, technically, that is one of the most important message for our youngsters, that you must be comfortable with dealing with the hiatus if you want to do bariatric surgery.
Excellent. Sir, regarding size, because some technical question. So regarding gastroesophage size, so is it important for you?
I think gastroesophage it is important because the principle you're working on is that you have a small reservoir that you eat and fill, and then it should slowly release the food into the jejunum. If the gastroesophage is very large, then essentially it acts as a continuous tube where you put the food and it continuously goes in. It may contribute to dumping, but it also may contribute to either lack of weight loss or weight regain. I don't think it's an absolute entity in its own right, but it is a contributing factor. And I know it from the fact that when people have gone back with Roux-en-Y bypass patients who had lost weight and then regained weight, they made the gastroesophage smaller, either endoscopically by APC and stitching, or by excising the whole jejunum and making it sort of a sleeving the complex, and with initial good results, but not long-term good results. So we know that it contributes, but in its own right, it's not one factor. So I use a 34 to 36 French orogastric tube when I construct my pouch. So right at the beginning, that tube empties the stomach for me. Then when I'm making my pouch, after I fire my transverse staplers at the bottom, every time I fire the vertical stapler, the tube comes in to make sure that the pouch is not too narrow. And then when I make the gastroesophage with a hand suture, then when I make the anastomosis, it needs to pass through the anastomosis to make sure that it's not too narrow. And then the same tube is used for methylene blue testing. So this tube does a lot of functions, and it sort of guides me as to the size of the pouch, size of the gastroesophage as well.
Sir, you have mentioned, so you have used many years also circular, you have used linear, and now also handson for gastroesophage. Have you any data to compare marginal ulcer in these three techniques? Or no, there was no difference?
I've not used the linear stapler. I've used the circular stapler and the handson. We actually published, when I was in UK, we published with a center in London and compared our handson with a linear stapler. The weight loss, marginal ulcers, remission of diabetes, there was actually no difference. The operating times at the beginning of the curve are higher with handson, but as you get proficient with it, then the operating times are very comparable. I'm not aware, apart from when you use a circular stapler, with a smaller 21 circular stapler, then the stricture rate is high. The studies that I've read, the linear stapler has the least rate of stricture. Both circular stapler and handson have, I would say, between 1 to 5% stricture rate. Ulcer is more dependent on smoking and on non-steroidal anti-inflammatories and how patients use it. If you leave a large pouch which has a capacity to produce acid, then that can lead to ulcers as well, or if there's a fistula.
One question, so maybe this is, I have no idea it's a good question or not, because our viewers also have this question. Because I remember when I was resident at an earlier stage of my surgery, at that time, there was no PPI. And I remember many times, so we did this enterectomy and such a surgeries for recurrent peptic ulcers. Also, I remember that vagotomy and highly selective vagotomy and different types of surgeries. At that time, open surgery we did, and I remember. So what is your opinion? Is it effective, or have you any experience for this? Because now in Roux-en-Y, we have the main challenge is, yes, we have internal hernia, we will discuss, but one of the challenge is marginal ulcer. So is it effective to go for vagotomy?
Imran, we had a patient who came to us from an outside practice with marginal ulcers, and we did our usual. We excluded the H. pylori. We gave high dose of PPI, double dose PPI and sucralfate. And the patient, we tested for nicotine, and the patient was negative. And then we were really at a loss, and the pouch was small. So resecting and re-anastomosing was not such a great option either.
Yes.
And we did actually discuss this among the group as should we consider, and we discussed and we concluded that the vagotomy would do what? It would reduce the acid burden on that. And with our modern proton pump inhibitors, they can reduce the acid to zero. Dexilant with your newer PPIs are very, very powerful.
Yeah.
And by doing vagotomies, number one, I think people have sort of forgotten how to do vagotomies because it's not required. Secondly, we actually looked in the literature and we couldn't find an additional benefit of doing the vagotomy and in modern practice, even leaving the bariatric surgery alone, in the benign ulcer disease, vagotomy is not practiced anymore. At least in my UK career and when I was in my training, I did not see a single vagotomy. And this is, I'm talking about 20 years ago now. So in my view, vagotomy does not have any role in modern practice.
Sir, so one of the concern, and not only concern, one of the, I think, nightmare after Roux-en-Y is internal hernia. And always the debate is closing the defects and how we close. Yes, we must close. Now I can ask more than 90%, yes, close. How we close? Interrupted suture and also pierced suture. So it depends on your experience. What is your preference? And also I want to hear about from your side, you close the defect, again your patient consult with internal hernia.
That's an excellent question, Imran. I'm glad you asked, and I will share a recent experience as well. So, number one, internal hernia is a lifelong complication after Roux-en-Y reconstruction, either for bariatrics or for non-bariatrics. And if you look at many people who have published 5-year data, that their internal hernia rate is only 1% or less than 1%. So number one, you need to look at 25 years worth of data, because once you've done that reconstruction, I've seen internal hernias longer than 10 years after this, and they have been reported elsewhere. Secondly, your patients don't always end up in your hospital with that complication. They might have gone elsewhere. And unless you have a comprehensive health network where everything is reported back to you, you would miss on those. Thirdly, closing the internal hernia does not guarantee that you will not have an internal hernia. And that is very clear in my mind. It reduces the chances of internal hernia. It does not eliminate the chance of internal hernia. One thing that I think everyone agrees is that the mesenteric defect must always be closed. I don't think there is any debate on that. I don't think there's any debate either that a non-absorbable material should be used for that. So that debate is gone. If someone is still debating that, then I think we just need to ignore them.
Yeah.
Because that debate is settled. There is still some debate about the Peterson or pseudo-Peterson space. When you go anteriorly, pseudo-Peterson. And there are surgeons who, including my trainer, who did not close the pseudo-Peterson. And I went back to him after a few years discussing something, and he said he started closing them. And I said, why? He said, because I had an internal hernia. One of my patients came back. So as surgeons, I think our practice sort of changes with our experiences. And if you've been in one place long enough, you will see your complication. If you've been moving around a lot, you may think that in your hands, patients do not get complications. But if you stay at one place longer than 5 years, that's when you really see the shortcomings of your technique and your surgery. And I think it is important to be able to do that and look at your practice. So the technique-wise, my preferred suture material is Ethibond. And I always close, and my starting point is at the bottom where there's a V in the JJ anastomosis in the mesentery, and also in the pseudo-Peterson space between the mesentery of the transverse colon and the mesentery of the small bowel. There is a V. So I start with the V. Now I'm quite meticulous about closing that. And this Saturday, I was called early hours of the morning that one of my patients who had a bypass in December had come back with 4 hours history of sudden onset abdominal pain. And they'd done a CT in the emergency department, and it showed trapped bowel. So we brought that patient straight from emergency to OR. Within a few hours, we were able to explore her laparoscope, and there was a knuckle of bowel looking very blue. And that was from the pseudo-Peterson space. So while this patient was before surgery, when she was being anesthetized, I had a chance to look at the video. And I looked at the video, and I had closed the defect. I had closed it myself with the material that I normally use. So I couldn't blame my trainee for that. And the closure was as satisfactory as I could. And when I explored her, one of the stitch from the lower part had actually come off the fat. And that opened a small defect, and that trapped the bowel. So one of the arguments that people use is you either don't close, or the worst is to close badly. If you open a big space, the chances are bowel will come and go out again. But if there's a small defect, then you will get trapped. Fortunately, we were able to salvage this patient's bowel, and once we opened it, the color changed. But what I wanted to, and this has been, I think, at least 4 or 5 years since I've seen one of my own this soon. It's very humbling to know that even with the best way you do it, and I've changed my technique slightly based on this, there's always a chance. And I think it's worth telling your patients that if you get sudden onset of abdominal pain, then you must try to get to the closest hospital, preferably the one that does bariatric surgery. So yes, this remains an important issue in Roux bypass.
Sir, you are also naming this pseudo Peterson and Peterson, because I remember in a debate, one of a well-known bariatric surgeon. So we were discussing about this, and he was not accepting. So because now they think, okay, this is that you are asking pseudo Peterson, that is Peterson, but Peterson is retrocolic. Are you agree?
So yes. So I think traditionally, when in Roux reconstruction, and when you take the jejunum up to join with the stomach behind the transverse colon, you have to create a defect in the mesocolon. So that defect, where it is passing through the mesentery of the transverse colon, that is the Peterson defect. In anterior approach, where it's anticolic, it does not go through that, but there is a defect between the mesentery of the small bowel and the mesentery of the transverse. That's the V.
Yeah.
So that is the pseudo-Peterson. That's my understanding of it.
Sir, which percentage of your patients after Roux gastric bypass are suffering with weight regain? Now more than, I think, 1.5 decades, 17 years, you are following your patients. Which percentage are suffering with weight regain, and what do you prefer surgically?
So I think the natural, so if you look at the natural way history of gastric bypass is that they lose weight first year to 18 months, and then they sort of plateau, and then they regain about 5 to 7 kilograms, and then they tend to stabilize on that. So that is what I accept as a natural cycle of weight regain and relative stability. So the two groups, one where they do not lose the desired weight, and the secondly, which lost weight, but then they regained to a level which is not acceptable, both in terms of weight loss and in terms of the resolution of comorbid conditions. I think I would say about 15% of the patients would gain weight with gastric bypass to a degree that they would need something else doing. Our approach for that is that we don't think of surgery to begin with. So the important thing is that they need to go through the MDT. Dietitians need to assess, and vast majority would have things to adjust in their diet. They're snacking, they're eating high-calorie diets, and they're not careful with what they eat and when they eat. They also need psychological assessment. So for weight regain, we do both of these always. Thirdly, the anatomy. So for weight regain after bypass, I always do an endoscopy, and I always do an upper GI study just to look at the anatomy, the pouch size, the stoma size, GJ anastomosis size, and the patient factors. And a lot of times, by reducing the stoma, you get a good idea of how they would behave afterwards. And one of the simpler things, you can either use the overstitch to make it smaller, or you can just do an APC fulgration of that, and that gives scarring. It's temporary. Even the stitch, we stitched, and after 6 months you scope and the stitch is gone. But they do get some measure of how the weight loss would be. I tend to now ask my endocrinologist to give them medication for weight loss. So I think as surgeons, when you're a hammer, everything looks like a nail. You want to operate, and I think as you get a bit more experience, the temptation to reoperate is less, and you want to make sure that even after reoperation, that patient is going to be your responsibility if they don't lose weight. So I don't sell the next operation very easily to my weight regainers after bypass. After going all through that, if I have to operate, then I do a distalization of the BP limb. And I think you and I spoke about it after one of the meetings. We basically divide the roux limb where it joins the where the jejunum is joined to jejunum, and then rejoin that roux about 300 centimeter from the ileocecal valve proximally. So you leave a 300 centimeter common channel. So that's the distalization that has worked mostly in my hands, although some patients do have very significant nutritional deficiencies, and I had to reverse one of the patients back to the pre-distalization anatomy because of that. So I think you need to be careful that the patients are able to eat a lot of protein, and they will take the double dose of their nutritional supplements. And if they're not going to do that, then do not rush to offer this. It's technically not a very difficult operation to do, but can be very difficult to look after if the patients are not compliant.
Agree, sir. Sir, excellent, sir. Sir, what is your main concern and complication after Roux-en-Y gastric bypass?
So I think one of the long-term complications that I worry about is the internal hernia, because it can happen at 10 years, 15 years down the line. And if the patient ends up in a hospital that is not familiar with Roux-en-Y or bariatric surgery, people usually, and this is true for most of the surgeons, for bowel obstruction, we look for vomiting, we look for constipation or absolute constipation, and we look for abdominal distension. And post Roux-en-Y, all of this could be missing. Patients, they just have pain, and pain can be out of proportion. If you're more lucky, then the patient may come in the clinic and say, I get sometimes this abdominal pain. It's very bad, and I do get some distension of the abdomen, and then after some time it goes away. And that gives you a hint that there may be an internal hernia which sort of reduces by itself. My routine in those cases is to do an ultrasound scan if the patient didn't have the laparoscopic cholecystectomy, because gallstone is quite common. Secondly, do an endoscopy to rule out any ulcers or H. pylori. And if you don't have either of those, then do a CT, preferably when they have symptoms. And I tell them that if you get that episode again, go to the nearest emergency, ask them to do a CT scan. The chance of finding an internal hernia is maximum at that time. And if all of this is negative, and if I have concern, I do a laparoscopy. And I examine the hernias, and if there's any defect, I close it. If not, then I know that they're not at risk of losing bowel. So that is something I worry long term. Secondly, patients who tend not to come for follow-up and they do not take their supplements, especially the ones who had slightly longer BP limbs, then they're likely to develop more malnutrition and micronutrient deficiencies, and those are the patients that I worry about.
Regarding supplements, how long time and which supplements you prefer after Roux-en-Y gastric bypass?
So our routine is that everyone gets a chewable vitamin for the first 6 weeks. It's a multivitamin A, D, E, K. And then after 6 weeks, we switch them to a multivitamin which has plenty of iron in it. And then there are 3 or 4 different brands. And from US, you can get the bariatric specific ones as well. They always get a calcium and vitamin D supplements. And roughly every 3 months, they get either a B12 injection or they get B12 tablets. Injection is more predictable, the calcium should be citrate rather than oxalate because that's a better absorbed form. We do blood tests pre-op. We screen for about 9 or 10 things pre-op. And then 3 to 6 months after surgery, we do a full workup again. If everything is okay, then they get one done at year and then yearly after that. If something was very deficient, then we would repeat it in 3 to 6 months to make sure that all those deficiencies. Our patients are routinely followed up by either our endocrinologist or by our internal medicine, and they know the routine of doing bloods and giving the extra supplements.
Sir, excellent. Sir, do you think Roux-en-Y has a long-term future? So what is your opinion?
I think it does, although if you look at the history of, in the last 20 years of bariatric surgery, I sort of started bariatrics when band was at the top. In fact, Derby, where I worked, we were the largest band provider in UK on the NHS. We were doing 300 to 400 bands a year at that time. And globally, it was the most frequently performed procedure. And then the band went down, and the sleeve is now currently the most frequently performed procedure. I think the mini bypass or OAGB may be in that situation in the next 5 years. But the future of Roux-en-Y, I think even if the numbers to do it as a primary procedure decrease and other more effective or easier procedures become available, then the primary procedure, it may lose favor as it has done many times over the last 20 years. But it has the validity to be a revisional procedure as a rescue procedure for a lot of problems in bariatric surgery. And again, my belief is that if you want to be a successful bariatric surgeon, then you must know how to do a Roux-en-Y because it rescues a lot of other procedures. And I'm not saying the others are bad, but every operation can have a complication. So that way, I think Roux-en-Y has a long-term future, at least during my working lifetime.
Sir, thank you. Thank you. Really, sir, it was a great session. And personally, I have learned a lot. So, sir, our last question, unfortunately, I like to talk more and more, but due to shortage of time, your message for youngsters and what path should the young surgeon take to train on bariatric surgery? So what is your suggestion?
So, Imran, I think I look at you and I look at your journey, and it reminds me in many ways of my own journey. And the things that I see which are common is your inner force to do something.
Yeah.
So unless you're motivated from within to do bariatric surgery, I think you can be a reasonable surgeon, but you can never be a great surgeon.
Yeah.
And if you have that drive within, then you will find people who will help you. You will find places where you can train. Look at you. You came up from a small town in Punjab, and then you made your way, and you now know personally some of the most respected surgeons around the globe.
Sure,
and no one sort of held your hand and took you to them. So my message is, if you're motivated from within, and I'm talking about people in Pakistan, people in Africa, people in Europe, where this specialty is not developed, there are plenty of well-trained surgeons who are also very keen to teach and train people irrespective of what they get back. So you need to find, number one, that inner strength, and then find the right people. And forums like this forum, I think this helps immensely, and it is helping immensely, and it is actually motivating a lot of people. So have a basic do it for the right reason, not just because bariatric surgery can give you a lot of money. You need to be good at something and money will come your way. You need to be honest to yourself that your first priority is patient safety and well-being, and everything then works around that. As long as you're trying to do it the right way, most of the things fall in place. I know that when you're working in a small hospital with commercial interests, it's very difficult to maintain all those principles and to follow all those protocols. But I think as long as you try to do it the right way, there is plenty of help around. Try to be honest to yourself and learn your basic skills. And there is a lot of now practice that you can do outside the patient. It's very cheap to find an operating training box and practice. I've spent days and days on that before going to my patient. My registrar, my trainees, I still give them a session on the training box. Once I'm happy with their suturing, that's when they suture on my patient. So there is, it is far more easier to train now. And my message is that if you want to train to become a bariatric surgeon, nothing can stop you. You will find your way, but it needs to be within you.
Sir, so much thanks, and really thanks of my viewers. So from all over the world, and I know now in India is the midnight, and in Europe evening time, we have viewers from Middle East, from Africa, from Europe, as well as from Asia. So much thanks, and we will continue our series of Roux-en-Y gastric bypass. Next week, we will be with another legend of bariatric surgery. Please follow our interview. If you have any question, you can ask personally and you can ask in comments. And especially if you have any question from Professor Javed Raza, you can ask in comments and he will answer. Again, so much thanks, sir. Really, it was great honor. This is reality. And it was one of my best session. So we need your support and guidance and in future, because this interview series will end in June 2022. Then we will continue from July onward. This sleeve plus surgeries or metabolic surgery in low BMI. And in 2023, we will go ahead the redo surgeries. And I can't believe till June 2023, all slots are booked. And I know which day, which surgeon, so I will interview. It is really great honor for me, and thanks all of you, that great surgeons that cooperate and at this platform of GLR. So much thanks, sir, and have a nice time, and see you again at an international forum. So much thanks, sir.
Thank you very much, Imran, for inviting me, and thank you to all the viewers who have tuned in. And I wish you the best of luck in your great this movement that you have started, and all these successes, may all the successes come your way. Thank you, man.
Thank you, sir. Thank you, sir.